Mm. Can you hear me, Kamo?
Yes, Dr. Bila, I can hear you.
You can hear me?
Yes.
Okay. Okay, thank you very much. And okay, colleagues, good evening, and thank you very much for joining us this evening. I hope you can all hear me. I had some challenges with my connectivity. There's a global problem of Microsoft Teams and Microsoft Office 365 all over the world. So I wasn't sure that we're also affected this evening on Zoom. But it doesn't look like Zoom is affected, so it could have been just some other glitch that one experienced. So sorry about that challenge that we are experiencing. So thank you that Clinics once more is welcoming you to this weekly webinars, and it's quite encouraging to see the beginning of this year that we've been getting quite a good response from those for our colleagues who've been joining us for these webinars. And we don't take that for granted, and we thank you for joining us every week. And this evening is also no exception that you've all come out again in great numbers. Please note that this is a Clinics webinar accredited CPD meeting and sponsored by Clinics since pandemic 2020. And note that also these webinars are streamed live on YouTube. So this makes it easy for anyone who has not been able to access the presentations online or the day of the time of the presentation, that you can also watch it later on. Or if you were part of the webinar and there's something that you want to go and check, you can always go back to the YouTube recordings and watch the webinar. We also request that you please, when you join us, when you register on the invitation that we send out on a weekly basis, that you provide your full details, name, surname, your registration number in terms of whether it's HPCSA or the Nursing Council, or Pharmacy Council, or the Allied Health Professions Council, so that when we submit information, we can forward it to the relevant entities so that they can allocate the necessary CPD points. And so this evening we are having one of the esteemed speakers, Professor Koto, who is a medical doctor by qualification and MPhD from Medunsa or Stockholm University of Health Sciences, and has got a fellowship in surgery from the CMSA South Africa and also the American College of Surgeons, and a certified GIT specialist, and also a Royal College from Harvard, and also holds a PhD from the University of Natal. We've shared his CV there, and I do not want to go through that again this evening at the sake of time, and that we are looking forward to hearing him talk about shaping the future of trauma care, the vital role of laparoscopy. And so we're quite excited, Prof. Koto, for you joining us this evening. And one thing that maybe most people may not know, that you're part of the consultants who are advising Clinics Health Group on patient safety and quality of care, and you're the chairperson of our Clinics Risk Committee. And we're quite excited to have you once more joining us this evening. Thank you.
Yeah, no, thank you very much, Dr. Bila. Am I audible? Am I audible? Can you hear
on
me?
my side, it is not that audible. I don't know, Kamo, how's the sound from Prof. Koto?
I can hear him clearly.
Okay, mute on my side.
Yes.
All right. Okay, no, thank you very much, Dr. Bila. First of all, let me thank Clinics Health Group for this opportunity to share with colleagues my thoughts around the role of laparoscopy in trauma. It is indeed a great honor and privilege for me to, again, to be here with you and basically reflect, my journey, in the utilization of trauma as an intervention strategy in patients with penetrating trauma as well as blunt trauma. I do not take this opportunity lightly. Certainly, I want to again, once again, acknowledge, the great opportunity given to me by clinics, and I am really privileged, to be on the podium this evening to talk about something that really is very, very close to my heart, which is the utilization of laparoscopy in the management of trauma patients. Now, if you look at the evolution of trauma, this is what I like to talk about. It has really been an interesting and colorful journey. And it is really fascinating to see how far we have traveled, as surgeons, in utilization of trauma, of laparoscopy in trauma. It really begins, back in the 1990s, around 1993, the paper by Ivachuri and colleagues looking at the utility of laparoscopy in penetrating trauma. And basically, this paper, raised some concern around the sensitivity of laparoscopy in picking up injuries, particularly in picking up viscous injury. And that paper, which I will certainly reflect in my talk this evening, basically raised some very concerning, which is the sensitivity of trauma for diagnosis of hollow viscous injury was as low as 18%. So in other words, 80% of patients with hollow viscous injury there's a potential for missing those injuries. Again, this certainly threw the spanner in the works because a lot of trauma centers, including the one by Dimitri's in Los Angeles, certainly banned, laparoscopy in managing trauma patients. Certainly, it was a taboo, to utilize this type of intervention in managing trauma. But I think really we've made steady progress over the years. And many, investigators have shown the safety of laparoscopy in managing penetrating trauma. Now, if you look at laparoscopy in general, it certainly is just utilized, in many areas. For example, in removal of the gallbladder, laparoscopic cholecystectomy is well established. There's lots of data, showing the safety of laparoscopy in cholecystectomy. It is now considered a standard of care in many other areas. For example, removing the appendix today, laparoscopy is a standard of care. But when it comes to trauma, there has been this fierce, area of contestation, sadly for good measure. And a lot of this, hopefully, at the end of my talks, and I can be able then to deliberate and discuss, with the audience as to some of my thoughts around as to why, it has been fiercely contested. But I think over time, certainly there has been lots of data that is coming out throughout the world, and certainly in South Africa, showing again the safety and the utility, usefulness of laparoscopy in managing trauma patients. This is the familiar scene in South Africa. You see these are patients that we've managed in our trauma unit, and these are impaled injuries. This individual had a stabbed chest, the knife was stuck. And this was a lady who was stabbed at the back, the knife was stuck. And this was an individual stabbed in the precordium, chest area, knife stuck. And this is another individual at the back. This was a student who was brought, from Limpopo in a helicopter, again with a knife, impaled. And this is so this is very common in South Africa, this kind of scenes. This is the X-ray showing again a knife inside. And, this is another picture again. This is a patient that was seen in recent past, a few weeks ago, who was involved in blunt trauma from a road traffic accident where there were several members of the family that demised on the scene. As you can see here, you can see clearly, the mediastinal shift in this patient and, the nasogastric chip in the chest. you know, and then absence of lung markings, you know, again, huge diaphragmatic hernia with the stomach, the colon there's inside the chest. Again, this the picture that I showed earlier, you know, this patient was offered, you know, cross-sectional imaging. As you can see, this is a sagittal view. You can see there's the knife going through, you know. So again, for the sake of time, I am not showing the cross-sectional, the axial view, but basically they missed, you know, the major vessels. So this was done by our residents or registrars. And this is a video of the same patient, as you can see here. Now, if you look very carefully there, you can see there's a knife there. This is the left lobe of the liver. That's the spleen there. There's the knife. Now somebody is pulling the knife out. As you can see, the knife is disappearing there. The knife has disappeared. So once again, this patient was saved, you know, a major laparoscopy, and this patient was discharged, you know, after a few days. But this is the chest X-ray that I showed earlier of the patient with ruptured diaphragm. As you can see here, that's the left lobe of the liver. You can see here, this is the stomach, and all of this really is in the chest. And here, the laparoscope was done, and as you can see here, there's a grasp again pulling the contents of, you know, this hernia, the stomach again, as you can see, omentum, everything inside the chest there. Now here you can see here, it's the hole that was left. And here's another view of the similar hole again. And this is the diaphragm that is now being repaired. And this patient again did well, again, was saved, you know, a major laparotomy. You know, these are some of the patient here. You can see here, this is a patient with blunt trauma with a penetrating or perforation of the small bowel. This is a patient, a precordial step, you know, basically that shows, you know, you can see the laceration of the pericardium there. Again, because this patient was very stable, there was no need really to offer this patient thoracotomy. As one of the other patients that you can see here, you know, the diaphragm is completely, there's a huge laceration of diaphragm. You can see the ribs from the abdomen side. This is the left lobe of the liver. So once again, these are patients that are saved, you know, the morbidity of a laparotomy. This is another patient that we had, you know, who had a transthoracic or thoracoabdominal gunshot and had a acute abdomen. Now, the discussion really was whether or not there was injury in the heart. So we offered this patient laparoscopy, and there was several injuries in the abdomen that were fixed. But very importantly, you know, we did a transdiaphragmatic pericardial window. As you can see here, this is the diaphragm that has been opened. There's the heart inside. And this patient had a positive pericardial window that necessitated us to explore the chest, and the patient had a stenotomy there. So this is this patient, as you can see here, this is the gunshot here. We've had to extend this, you know, to sort out that. So here in the abdomen, again, this patient has been saved, you know, a major laparotomy. And we were able to offer him a stenotomy because the pericardial window was positive, indicating a cardiac injury. So this is the paper that I spoke about, you know, by Eva Churi, which was published in the Journal of Trauma in 1993. And it really talks to one of the problems that certainly, you know, has raised, you know, concerns around trauma surgery, which is really the issue of missed small bowel injury, or yet, injuries that are not detected. And in this particular publication, they found that the sensitivity of picking hollow viscous injury was low as 18%. You know, again, this is really a great concern. But again, if you look at the publication date, this is 1993, before the election, so it's many, many years ago. And we've come a long way in terms of imaging, you know, technology. You know, we now have 4K systems, cameras that can see so well. You know, the instrumentation has improved, but very importantly, you know, the technical skills in laparoscopic surgery has improved in leaps and bounds. And so the findings here, you know, of sensitivity that is low as 18% are no longer applicable today. Now, there's been a few other studies. This was a meta-analysis that was a systemic review that was published by O'Malley in World Journal of Surgery in 2013. And this comprised 251 studies, of which 13 were prospective, involving well over 2,500 patients. And a positive injury was found in 44%. Therapeutic laparoscopy was possible in 14%. And then again, conversion. Look at the conversion here. Quite a significant conversion rate, 34%. And missed injury 3.2. Once again, is 2013. But again, we've come a long way, since the publication of this systemic review by O'Malley. Things certainly have improved quite significantly. This is another patient. As you can see, this patient had a gunshot. This is a grasper probing the injury here, which can then be repaired, intracorporeal. This is another patient that had a colon injury from a gunshot. Here again, you can see clearly here, the injury has been now repaired, intracorporeal. Again, saving this patient the morbidity of a major laparotomy. And we know that, if we do routine laparotomy for abdominal stab wounds, the concerns are that, nearly a third to half of these patients do not have penetration of the peritoneal cavity. So in essence, they end up with unnecessary laparotomy. And even those that have penetration, quite a significant number, up to 40% of them, do not have a significant injury that requires intervention. But very importantly, to remember the morbidity of laparotomy. It can be as high as 20%, even mortality. And in the long term, these patients certainly can have bowel obstruction. So laparotomy is not without problems. What are then the indications for laparoscopy in trauma? Again, it really is for diagnosis of peritoneal penetration. It is very good in diagnosing diaphragmatic injury. And in some instances where, abdominal examination is equivocal, you want to see if there's significant injury intraperitoneally, laparoscopy certainly is very, very helpful. And of course, therapy, therapeutic role has got, I think it really is taking now center stage to the extent that, in our unit, step abdomen that are stable, the standard of care is laparoscopy. Those patients are not opened up, they are offered laparoscopy. And when the process now of writing a paper, basically looking at our own experiences of well over 200 patients in the last 2 years that we have done laparoscopy in. And of course, in creation of the transdiaphragmatic pericardial window, as I've shown. The contraindication, of course, is hemodynamic instability. Those patients that are not stable, we certainly would not offer them laparoscopy. Anybody else, I think, with a step abdomen, today, the standard of care certainly is laparoscopy. Again, for its therapeutic role, solid organs for liver injury, those patients that are stable, have liver injury, we can suture that. We use a liver suture, do intracorporeal suture, mattress suture, diaphragmatic repair, certainly, and hollow viscous repair in these patients. There are certain potential complications and limitations of laparoscopy in penetrating injury. One of those anesthesia complications. Some of these patients are certainly unstable from an anesthetic standpoint. Tension pneumothorax is something to watch out, especially for those patients with thoracoabdominal injuries. Of course, gas embolism, that is rare, but it's something that one has got to watch out for. Of course, hemodynamic compromise, because of the positive pneumoperitoneum, there are significant hemodynamic changes that can occur, especially patients that are hemodynamically unstable. Of course, iatrogenic injuries, one has got to be very, very careful. Entry, using a trocar entry, one has to be careful that you don't cause graspers, the way we use, careful selection of atraumatic graspers, the careful handling of bowel, very, very important that one does not cause iatrogenic injury. Of course, missed injuries remain a problem that certainly must be watched out for. What is our own experience? Sorry, I just want to go back again. Now, I was trying to see, I think I'll have to, just 1 second, show, yeah. Yeah, these are some of the publications that we have done over the years. In 2012, we published our experience, our initial experience. In 2013, we looked at again the role of laparoscopy in management of stable patients with organ evisceration. And then in later, we then in 2016 we look at laparoscopy assisted approach for penetrating abdominal trauma, an underutilized technique. And we then looked at our experiences using this particular technique in managing patients, especially patients with gunshot injuries. Around 2016, we look at the use of laparoscopy in managing penetrating thoracoabdominal injury. We published this in the World Journal of Emergency Surgery. And around 2017, we looked at trauma laparoscopy, when to start and when to end. And then there's been other areas that we've looked at. The one was evaluation of thoracoscopy with single lumen and a tracheal tube. This is the work that was done by Landon Zagala, and others certainly. And then we looked at the awake emergency department thoracoscopy, investigating penetrating diaphragmatic injury, which also we published. And this was a very interesting article that was basically published by the American College of Surgeons, looking at laparoscopy in trauma. And just interestingly, this is some of the work that was cited from our own institution, really, as far as the utilization of laparoscopy in trauma. So this is a local paper, that was published in Pietermaritzburg, looking at thoracoabdominal injury and utilization of laparoscopy for diagnosis of left-sided diaphragmatic injury. And this is another paper that we looked at, basically looking at 83 cases of thoracoabdominal injury, managing them laparoscopically. So these are some of the patients that we see. For example, you see this individual here has got a step in the lower chest and has got omentum. So clearly this patient has had a diaphragm breached with omentum through. And this is what we found, inside. You can see here, there's a diaphragm here, and the omentum is gone through the diaphragm. Now, this is a patient, again, has got a thoracoabdominal step. You can see you see the spleen. This is the top of the spleen. This is inside the chest. Here, the patient has had, a diaphragm injury, and this was repaired, laparoscopically. You can see here now we have done a continuous suture with a non-absorbable suture, basically saving these patients, the morbidity of a laparotomy. This is a patient with a motor vehicle accident. Again, ruptured diaphragm here. You can see here there's omentum, everything is inside the chest. We have now reduced it, and here we're suturing this using continuous intracorporeal suture to close that diaphragm. Once again, saving these patients the morbidity of a thoracotomy. So this is just a video showing, again, here you can see we've now reduced that. This is the hole in the diaphragm. This is the left lobe of the liver. So we usually use a big needle. You can see here, we put it, you can't go through the port, you put it. And the reason for this is so that it gives you one movement. You can see one movement, it goes through the two lips of the laceration, and the needle doesn't disappear in the tissue. And very, very important. This is one of the things that we teach the registrars, that they use a big needle. It assists, especially when you're suturing this thick diaphragm. And here again, you can see just one swipe movement, you are able to go through both lips of the diaphragm. If you use a small needle, the size 26 millimeter needle, often it gives a bit of a problem. Now here you can see my scissors there. That's the public sector scissors. It doesn't cut very well. It's something that you don't see in the private sector, but here we're just making an intracorporeal knotting to close the diaphragm. Now, very importantly, after this, it's very important to check inside the abdomen. Has this patient got other injuries, in the abdomen? Once again, you can see how well you can see here. You can see very, very well. And then you see as we now investigate and examine the rest of the peritoneal cavity, that, again, in the systemic examination, it is very, very rare to miss injuries. So here now we have to repair the diaphragm. We just do what we would do ordinarily in a laparoscopy. Lift the liver up to see as an injury underneath. So we check in there, check the anterior part of the stomach. So we look and see pull the stomach down and see the fundus if there's anything. Again, we move them. You can see here, now we're looking at the colon. Again, you can see how clear that is. You can see, in terms of clarity of view, that, you can see here, you can see there's a fibrinous exudate. Clearly there's something there. You can see there is a hole. You can see the hole there. So we clear that. This patient has got a colon injury as well. So we probe it, a little bit just to make sure that indeed it is an opening. And you can see here the grasper goes nicely in. So that patient now needs to be sutured. And sometimes you find, a lot of fibrinous exudate in this patient. So one uses a swab inside just to do open surgery. Once again, you can see, using a suture intracorporeally, we suture the same way we do with open surgery, exactly the same way. So here we just go to open that. We usually use a monofilament like PDS suture because it doesn't cause tissue drag, so it moves with easily. And also in terms of knotting inside, it has got this springiness that allows you to do intracorporeal. You can see how it holds that loops very nicely in the air. I'm able to do my intracorporeal suturing. So we'll put that, and then I'm going to put a second suture again to close that hole. Just these two, suture repair should suffice, for that laceration. Now we've done that laceration. Now it's the zigzag maneuver, looking around exactly the same. We walk in the bowel. We walk the bowel. You can see here, you can see so well in terms of vision. You can see the vessel much better than with your naked eye in terms of, injuries. Once again, we'll run the bowel, and we'll talk about that, as we move along. Right. Now, sometimes you get, organ evisceration, and this is an area which is quite controversial. The Walter Biffle and his colleagues published, their data, a few years ago, basically looking at anterior stages of evisceration. And they found that actually a significant number of these patients had injury that required intervention. There's a bit of echo there. I don't know if somebody can just close if somebody can just close their mics. Yeah. Okay. I think the echo is gone. Yeah. So again, we looked at that, and this is one of the things that we looked, and in their series, more than 350 patients, they found that if there is organ evisceration, those patients have got a significant intraperitoneal injuries, and actually that warrants laparotomy. So we did a similar study, but in this particular instance, we're looking at the role of laparoscopy, in organ evisceration. Now, the laparoscopic assisted technique in trauma, because sometimes you get a gunshot, and gunshot has got 14 holes in the bowel. You can do those laparoscopically, but then it takes, a fairly long time to do them individually. Even resection, you can do resection laparoscopically. There's no problem at all. And this is one of the things that we try to teach registrars, to do intracorporeal resection, usually under GIA, because it's a very easy thing to do laparoscopically. Resect that small lupo bowel, and do a functional side-to-side anastomosis. But sometimes the surgeon may not be very confident in doing intracorporeal resection and intracorporeal suturing. In that case, then we advocate, the laparoscopic assisted technique. And this is the paper that we published, they're looking at this particular area of, essentially what you do, as you can see here, this is a patient with a bowel inside. He's got a hole there. So we then push this bowel inside the peritoneal cavity. If there are, resections that needs to be done, we can resect that, or make a small little incision, 4 to 6 centimeter incision that we can then resect the bowel, outside, and this certainly assists, in shortening the operation time, especially those people who are not very comfortable in doing intracorporeal anastomosis, you can do that outside. But this patient still ends up with a small incision on the abdomen and still have or gets the benefit of minimal access surgeries. Again, it's almost like colon resection. For example, you do a right hemicolectomy, you would then, for specimen extraction, Yeah, unless you are doing a natural orifice where you do a transrectal extraction of the specimen, we usually still make a small little incision, but those patients still have, huge advantage, in terms of, minimal access surgery. Now, what are the steps, for laparoscopy for trauma? Firstly, you need access, you need access. Usually around the umbilicus is usually the best access. Some of these patients have had previous laparotomy. So if there's previous laparotomy, usually use the right or the left subcostal space, the so-called Palmer's point, to access that and then look for adhesions, and be able to take those down. But any other patient that doesn't have a previous laparotomy, we would go through the umbilicus. Either you go through open Hassan technique. Usually encourage the registrars to do open Hassan technique, insufflate, and then pararectal. And usually we use a pyramid, a port placement, which is what I will explain a little bit later in the talk. And then, of course, pneumoperitoneum. Pneumoperitoneum, especially these patients, we will go, usually it's not necessary to go 15, around 12 millimeters of mercury, is sufficient. Sometimes you might have to go higher than that, but 12 millimeters of mercury is enough. And then, of course, the first thing would be the quick assessment of the abdomen and bleeding control. So we're looking for bleeding, and the important thing again is to use a Johansson. It's a very long grasper. I think the one that was using in walking the bowel. It's a 4 centimeter grasper, 4 to 5 centimeter grasper, the jaws. So you're able to grasp, whatever area is bleeding to control that. And then you can use suction, put a swab there, control that. And then decide, what to do. Does it need energy device? Does it need intracorporeal suturing? And it's very important, again, when you deal with this kind of thing, again, in terms of, control, and manipulation of the needle. Again, single-handed loading of a needle holder, which is one of the things that we stress with the registrar training, that, again, at home to train yourself to be able to load a needle, a laparoscopic needle with one hand, because one hand grabs the bleeder. Just like in open surgery, you put your hand down and then grasp the needle and be able to either put a figure of 8 to control the bleeding. And of course, after that is systemic inspection of the intraperitoneal organs. We also look at the retroperitoneal organs, and then you make a decision. Do I proceed with laparoscopy, or do I do a laparoscopic assisted approach, or do I convert? Again, conversion really would be the very last resort, where the patient now becomes hemodynamically unstable. Many of these patients, again, you would do, a very nice, laparoscopic assisted. Make a small little incision, 4 centimeters, eviscerate that bowel. It's amazing how much bowel you can pull outside. Look at that, resect that, do anastomosis by hand. You drop that bowel in, close that end, and that patient, again, will have the benefits of minimal access surgery. And of course, if you decide to proceed, are you doing a therapeutic procedure? You did fully laparoscopic? Are you doing it laparoscopic assisted? And then are you going to do intracorporeal completion, or do you going to eviscerate this outside, and do that outside? And then, of course, the extracorporeal, repair of the port side. So this is the pause that I was talking about. As you can see, it is really a pentagon directional. You can see here is an umbilicus port just below the rib cage, and then you see one midclavicular line, and then just below the iliac crest, pararectal area, that's the other one. And then, of course, sometimes you might have to put, the one in the suprapubic area. Again, before you start, the patient must be stable. Again, advanced laparoscopic skills, essential skills, but camera navigation, mobilization, intraperitoneal organs. But even then, again, which is something that has made people a little bit hesitant to utilize this. Even if you can't suture, put a port in, identify the injuries, eviscerate them, and do that, outside. The patient will still have a small little incision, like an appendix incision, and gets, the benefit of minimal access surgery. A quick assessment of the abdomen. If there's blood in the gastrointestinal or gastrointestinal blood and gastrointestinal contents, these are suctioned out, and then usually we are there to identify the injury area of bleeding, and then we control the bleeding, as I've already indicated. Now, there has been a lot of work done by investigators across the globe to deal with this problem that was raised in 1993 by Vachuri and colleagues, which is really around the problem of missed injuries. And basically, they looked at 75 patients. It was a prospective non-randomized study from Brazil. And they looked at 75 patients, of whom 60 were males, as expected, because trauma is a male disease. 38 of these patients had stab wounds, and 37 of them had gunshot wounds. Now, interestingly, the conversion rate was 26.6%. And the reason why they converted, they had what they call blind spot area. So Kawahara and his colleagues basically identified, and one of these areas is behind the spleen. So they felt behind the spleen is a blind spot area. And segment 7 of the liver, they considered that as a blind spot. Retroperitoneal area, they considered that as a blind. So if the patient had any of those, they converted the patient. But again, still, look at the accuracy. The accuracy, 98.6%. Remember the sensitivity? We've moved from 1993 from sensitivity of 18% to now 100%. And their conclusion was the laparoscopy was 100% effective in detecting small bowel injuries. Now, we took this further because what concerned us was the paper by Kawahara was that they had a fairly sizable number of conversion, because of the blind spot. And our view was that even the so-called blind spot, if you do a systematic examination, mobilize the colon, we can still identify injuries in this so-called blind spots. So this is basically the work that, or the suggestion that we made, basically is really to look at the right diaphragm, look at the right diaphragm and liver, and then you move across, to the left side of the diaphragm and look at now the spleen, that area. So from there you move to the stomach, anterior, inspect the stomach. And then remember the stomach, you look behind the stomach. You look posterior part of the stomach. So you look the gastrocolic omentum. It is open, flip the stomach open, just like we do with open operation. Look inside. Remember in the lesser sec, there's a pancreas. So then we look at the pancreas, the tail from the hilum of the spleen, the body of the pancreas, all the way to the head of the pancreas. And then in a systematic way, we look at the duodenum, the first part of the duodenum, the second part of the duodenum, all the way, and then trice ligament, the small bowel all the way to the ileocecal valve, and then up the colon, the ascending colon, the hepatic flexure, the transverse colon, the splenic flexure, descending colon, all the way down. And then we suggested, again, you repeated this because the whole idea is to avoid misinjuries. Once again, you go, and then when you do that, again, you jigger the bowel, to and fro, the chances of missing injuries are minimal, almost zero. So you do that. Now, some of the challenges are patients that come, delayed. There's fibrinous exudates. There's a little bit of things that, now there we liberal utilization of small swab, tonsillar swab, again, to rub off, that, fibrin, to making sure that, no injuries are missed. Again, if you do that routinely, again, through those 10 steps and back again, the chances of missing injuries are minimal. So this is, again, what we spoke about, again, as you can see, this is a patient with a gunshot. You can see blood here on and here we eviscerated one. Now look at that. This is a shattered, small bowel, injury, and many, many holes. So we've made a small, 4 centimeters. Now that bowel is outside. It's actually a laparotomy through a keyhole. You put your scope in, we're able to get this bowel through, and then you're able to resect it, and do whatever you have to do. If you have to do anastomosis, you do anastomosis. It's certainly very useful for gunshot injuries with multiple injuries, where you really abbreviate the laparotomy, shorten it and make it, a fairly quick operation. And when do we convert? Of course, if there's continuous bleeding, you can't see very well. It's a complex injury that involves major vessel injuries. The patient deteriorates, there is no point in persisting if the patient deteriorates. And if there's poor visibility, sometimes there's equipment failure, and you cannot see very well. In that case, then it is prudent then to convert the patient. So this is what you can see. This is a patient who has had a laparotomy. This is a laparotomy. He's got a stoma done. This is the one that has had, a assisted laparoscopic assisted procedure. And again, this patient, this one, second, if you come in the ward, the following day, walking around, this one will take them a couple of days to recover. Again, it's 4 to 8 centimeters, very small incision. Majority of them, especially the thin individual, 4 centimeters should suffice to get the bowel out and be able to do what is needed. And then, of course, we would then go and repair. So now this is just a flow chart diagram of how we manage this patient. They come in, they are unstable. If the patient is stable, again, whether hemodynamic stability, metabolic stability. Usually metabolic stability, you can look at that and then we'll always liaise with the anesthetist, basically to finding out, how the patient is doing intra-op. They do arterial blood gas, they'll be able to inform us, the lactate is this much, this patient pH is this much. So it's unstable. Of course, that patient really would not do a laparoscopy. I'm just going to go back a little bit because right. Yeah, so unstable, they must have a laparotomy. There's no discussion about that. And of course, if the patients are stable or they come unstable, they are responders to resuscitation, we make a decision. Is it non-operative management? This patient, we have assessed them, or they need operation, or they find this equivocal, we do laparoscopy for diagnosis, or the patient is clearly peritonitic, stable, we would then offer the patient laparoscopy. And then if, for example, those that we have offered non-operative management, if that fails, again, our port of call will be laparoscopy. Offer this patient laparoscopy first of all. And the majority of them, we're able to deal with them or deal with their injuries, through the laparoscope and not laparotomy. And then that for diagnosis, therapeutic, again, even if injury again, because again, now laparoscopy we do is very complex thing, we do all sorts of things laparoscopically. Suture, we do a intracorporeal gastric anastomosis, we do a bile duct anastomosis intracorporeal. So now injury with the bowel that's used like this really is not that challenging, certainly to do that. So that patient can be offered either resection. The majority of them is often repair, a small 1 centimeter injury that certainly can be repaired. And then, or you can do a laparoscopic assisted technique, and then you convert it back to laparotomy. If there's continuous bleeding, there is a complex injury, the patient deteriorates, there's poor visibility, as we said, and also equipment failure. So in conclusion, what does one do, to be able to do it yourself in laparoscopy? We know that diagnostic therapeutic laparoscopy is safe and accurate. It certainly is for hemodynamically stable patient. But what are the prerequisites? The patient must be stable, the surgeon must be proficient, the surgical team must be ready, equipment must be appropriate. And I think it begins, a new trajectory in the management of trauma. And that is really the training platform that the registrars, should be trained in this new, intervention. I think with us, we are now at the twilight of our careers, but I think it is very, very important that registrars that enter the training program, that, they are encouraged, seriously encouraged to take on laparoscopy and then demystify it, completely demystify it. And as we see, the more you do it, and the better it gets. And in fact, I've just seen now the registrar that get more confident, intracorporeal resection, they resect anastomosis. And now it takes, and puts you at a position where you can take on much more advanced laparoscopic work because now you really learned, as we've always done, that trauma is the kindergarten of surgery. This is where you learn to mobilize bowel, to do anastomosis. And the only difference that we are suggesting now, we do exactly the same thing, except this time we're doing it laparoscopically. And once again, it is, a walk, again, of many miles, or a journey of many miles. That's the first step. But once you are on it, certainly something that is achievable. I thank you for your attention.
Thank you very much, Prof. Koto, for this wonderful presentation on something that, as you say, laparoscopic surgery, which in trauma, and say trauma is a kindergarten of surgery. For a surgeon to be proficient, I know that it's people with the registrars, because they have been trained. So by the time if they're in your unit, by the time they complete their time in training, in your unit to become surgeons, they are quite proficient to using this mode of intervention. But what about those who have been in practice for some time and they're quite keen on learning the technique? What's your advice for such of the colleagues?
Yeah,
who are locked in now.
Yeah, I think it's certainly eminently possible. I think it requires, a very, well worked out strategy, and one of those is to do it every day, to do it continuously. It's almost like driving a car. You recall when you first started driving a car, it was always difficult. The more you drive, the better it gets. It's those little things, in other words, you start with the little things, laparoscopic, all of them, laparoscopic. So what it does, basically, it trains the hands, the eye, hands, psychomotor, skills, and some of the things, because, for example, to expose, certain tissue to move, the viscera in a certain direction to be able to see. These are, subconscious skills that you learn. For example, even when you drive, sometimes you don't think out carefully, for able to, turn this corner and I need to take the car without even thinking. But how do you get there? It's really through practice and consistency. And I think, that is the crux of this, is really through practice and consistency. So I think for a colleague that is already in practice, so my advice would be that, the little thing, if you're going to do an appendix, you do it appendix laparoscopic. You're going to do, you do it laparoscopic. You're going to do diagnosis, I do it laparoscopic, move the bowel this way. I'm going to do a little suture, I'm going to do it laparoscopic. Everything, I'm going to do it laparoscopic, little things, and then little things turns into bigger things, because now you develop your skill set, you develop that psychomotor ability, you develop that, subconscious, ability to do things, even without thinking. For example, I see, if I move this thing this way, this is not the right. I didn't even think, it just, it becomes a reflex almost. But you get to that level by really doing it often. For example, I've looked at the registrars, for example, I think something that may be a subject for a PhD study, to look at the registrar, they come in, and then they do this, and we insist on that. They will tell you, we insist, if he's done an appendix open, he must explain, why did you do it appendix open? So they come, they struggle with the port, and then by the time they're 2 years, now suddenly they go quickly, very quickly. And when you now teach them the more advanced things, for example, to work in a small space to do, total extraperitoneal hernia repair and so forth, suddenly you see them very quick. They're able to do it and learn so quickly. And the reason is because now they've done this continuously. At night, they struggle there, they sweat, they struggle, and then they get less. It gets less of a task because now they do it all the time. So in other words, almost every day when they come to theaters, laparoscope. And by the time they are now in third year of training, they've done, by the time they are 5 years now, we leave them alone. They can now do on their own. So I think the short answer to the question is that I think it's a consistency. I think you just need to consistency, repetition, that really ultimately helps. Yeah. And lastly, the thing that I found very useful, which is to invest in a needle holder. There are quite a few needle holders online you can buy. It doesn't have to be an expensive needle holder. And at home, again, these skills, of single-handed loading the needle, put the needle, in the right position. So we found that very, very useful. So when in the comfort of your home, when you come back at home, you sit on the sofa, you take your little needle with a sponge, a little bit, 20 minutes, you put it away. If you do that every day for 30 days, for 1 month, you become an expert. You become an expert. With just 20 minutes, I'm going to do this. First, you start with your eyes without using a 2D, iPad or camera. Now that is 3D because your eyes are 3D. And this has been shown again, has been validated, shown to be very effective. 3D, you load a needle with your hair, with your eyes. Load a needle, you suture with your eyes first, with your eyes. So now you build again that muscle memory, that psychomotor function. So when you now transpose this to a 2D image, you've now had a solid psychomotor, memory, muscle memory built, and it goes a lot faster now with the 2D. So I think it's one of the things that maybe to look at, certainly, I think going forward.
Yeah, you mentioned that the conversion rate is quite low, moving from laparoscopic surgery in trauma and going back to open surgery. What about those normal, elective case, non-trauma cases, and that end up in open laparotomy? Yeah. So what, is that an effect of operator scale proficiency, or what are the factors? I know you mentioned quite a number of indicators for why you want to go back to open surgery, but once someone has done that and they are then made to open surgery.
I think that's a great question. I think trauma, certainly for trauma, there was a firstly very high conversion rate initially. Now there's less and less conversion rate. But I think for elective surgery, conversion rate is a reality. I think to convert for a number of reasons. Sometimes, things are not very clear, and for safety of the patient, you want to convert. Sometimes you encounter significant bleed, for the safety of the patient, you would convert. Sometimes you convert because there is equipment failure. So yes, conversion, you're correct. I think the more skilled the individual is, the less conversion rate, without a doubt. For example, lab chole, there are units that hardly ever convert a lab chole. Lab chole, even if it's a difficult ones, they would do either fundus first and dissect it, or maybe a bailout procedure like a subtotal cholecystectomy without converting the patient. So I think you're absolutely correct, Ray, when you said it has also to do with the experience of the surgeon, the experience. But sometimes really the difficulty is just a difficult operation, not anticipated. Things are stuck, and you feel that for the safety of the patient, it's better to convert. So conversion is a reality, and it is one of the things that must be discussed, as part of the informed consent before the patient goes to theater. In other words, we're going to try laparoscopic, but remember there's a possibility that if things don't go well for whatever reason, we might have to convert to open operation. But you're absolutely, it's a function of the expertise and the skill and the experience of the surgeon.
Okay, thank you very much. There's a question from Dr. Kong. What's your view on the washout of abdominal cavity, where there's a content leakage or pus?
Interesting. I think that's a great question. Yeah, I think, previously, I think when we're training surgery, it has always been, the solution to pollution is dilution, is to wash out things. And we've done that, for decades. Generations of surgeons have always been taught that if there is pus inside, you must wash out. But then, in the era of evidence-based medicine, I think people began to question this, and the first study that I'm aware of was from Canada in children, children that had pus inside the abdomen. And these investigators basically randomized patients into two groups. One group were washed, the other groups were not washed. They mopped the pus out and they didn't do it. And then they looked at, a number of endpoints. One, reaccumulation rate or recollection rate, mortality, hospital stay. And actually there was no difference between the two, surprisingly. We'd expect, those that are washed out, they're pristine and clean, they should do better. This one or not. So it started there. And since that time, there's been several other studies that have been done. There's one in China that was done. There was one in Australia, a randomized trial, which was a non-inferiority study, also showing, non-inferiority of non-wash, of laparotomy, laparoscopy without washout. We did a similar study. One of our fellows, Imran Sadiwala, did one, a randomized trial in our own unit again. And it interestingly showed that, patients that were offered washout actually had more collections than the ones that were not offered washout. So now our standard of care is if there is pus in the abdomen, we don't wash out the patient. All of them, we don't wash out the patient. We simply mop here. And again, theoretically, if you think about it, the reason is that the body is trying to, to wall off this sepsis. There's macrophages in that area. So actually, you're doing harm by washing out this body immune defense mechanism that the body is trying to mount. You're actually diluting it, by washing out, So all these patients now that come with pus, no washout at all. And interestingly, the collection rate is not increased at all. No increased mortality. They do well, very, very well, surprisingly. So I think in laparotomy, there's often blood. We suction the blood out. Really, it's not really to wash out, this kind of patient. So we would not wash out this patient unless there's a lot of bile and what inside, which may cause, chemical peritonitis. Other than that, really, we're not very liberal on washout of these patients. Yes.
Okay. Quite interesting. And what's the incidence of gas embolism in laparoscopically managed cases? That's Dr. Pillay.
Yeah, I don't have the figure. It is not a common occurrence, and sometimes the anesthetist has got to be on alert, to pick it up. Suddenly the patients get tachycardia, and so gas embolism is rare. It's rare. It is possible, but very, very rare. And I think I've seen 2 in my career. I've seen 2 patients with gas embolism. They did settle, but it's certainly rare. I don't have a figure how many. I don't know if but it's a rare complication.
Yeah. Now, Dr. Mahuma wants to know, we live in the AI time and robotics. Any prospect of robotics assistance in the near future?
Interestingly, I think it's very, very interesting. There certainly has been now, an attempt certainly to see whether AI certainly can assist in these patients. I think that a lot has certainly happened, but I think the bottom line is you still need a surgeon, to manage this, but we don't know maybe 10 years from now how the future will pan out, whether, you'll be able to, tell the robot, and, it goes and does the operation. But I think really the robot really is a slave master arrangement. Basically, it's not really a true robot. For example, you look at the Da Vinci and others generation robots that are now available. They're not true robots because you still sit there on the console. You sit on the console and basically tell it, you move this instrument, this, you grasp that, grasp this. So basically, you do the work, the machine does it. It takes away, tremors, it takes away. So the steadiness is there, it's much, much better. It gives you the wrist movement, but it's still you operating. So because a true robot should be, I should sit in my kitchen and then it goes in the theater and then it does the operation. Go and do it and then I program it without me being there. And it does the operation. So I think it's something that is coming. I'm sure it will happen, certainly not in a so distant future, but it's something certainly that will happen. But at the moment, I think it's really fascinating AI, really how, especially the repetition of things, how it certainly is beginning to transform the way we work. But really, we're watching that space keenly and see how it's going to pan out. Yes.
You still need a physical person to do the search. Maybe just to clear, it looks like perhaps the message was not so clear as to who does this intervention using laparoscopy. A patient comes with a knife or gunshot, and they arrive at the emergency department. So it is not necessarily the casualty officer, the medical officer, or the emergency physician who's going to be attending to this patient. They will stabilize the patient, and the patient will go to theater. Is that the case? There's a question here that say that the issue is that, casualty officers may not have the skill. So maybe just to clarify that.
Yeah, no, I think certainly the role of the emergency care physician or the casualty officer is to identify the patient, stabilize the patient, and call the trauma surgeon or call the surgeon, who will then come, and make a decision whether the patient requires an operation or not, or whether they are going to offer the patient a non-operative strategy. clearly the unstable patient, that decision has got to be made upfront. This patient is unstable, it's a non-responder to resuscitation, so he goes to the operating room, so there's no discussion there. But majority of them, they come in, the anterior abdominal stab wounds, they're very stable, both hemodynamically and metabolically, they're stable. So you have everything, to assess them. You can do a fast on them or focused abdominal ultrasound examination in trauma on them, assess them properly, and then call, the surgeon comes in and then make a decision. So clearly those are patients that are stable, and the person who manages them is a surgeon. Is the surgeon going to operate them? And indeed, I think today, a step abdomen, really, it's really a tragedy to have a stable step abdomen. You have a laparotomy today in 2024. Really is a tragedy. It's an absolute tragedy. And I think, it should actually be considered, my view, maybe it's a strong view, unethical in my view. Many people may not agree with, but I think it's unethical. I think in this day and age, a step abdomen which is stable, you do a laparotomy, that it should be considered unethical. It's almost like removing a gallbladder with a laparotomy. I think today, because there's better technology to do this patient, the same operation with the same outcome, do it laparoscopically. I think the issue really is around, imparting skills to the trainees and changing the landscape of training to making sure that these individuals are able to do this operation without, a difficult. It's almost like having a car at home. You have a car at home, but then because you don't know how to drive, you leave the car in the garage, you go and look for a lift or a taxi somewhere outside. So the solution there would be you go to driving school and how to drive, because it's so much better to use your own car for transport to get to work. So I think it's the same thing again. The laparoscope really is about how do we then impart the knowledge? And it's not rocket science, it's not very difficult thing. Something eminently achievable can be done, by everybody, so that, these patients then can then be offered lap scope and repair. Then they go home, in 2 days they go home.
But given the scarcity of resources, especially in the public sector, these patients who arrive at a regional hospital, maybe a district hospital, and you have a provision surgeon, but the resource, the equipment, would every hospital have the laparoscopic sec to be able to perform these procedures?
Yeah, I think that's a great question. And this is one of the things that I think we, a few years ago, I was part of the delegation that discussed, through the West African College of Surgery, global surgery discussion around, making surgery accessible on the continent. And one of the things that we raised was, or I raised certainly was, and then somebody said, no, you can't talk about laparoscopy. That thing is, I think it is that mindset. Laparoscopy is almost laparoscopy, something that is high up there, very, very difficult. I think, if you look at some of the costs of equipment, for example, an anesthetic machine, you buy an anesthetic machine for a district hospital. An anesthetic machine is almost the same, some of even cheaper than, the laparoscope machine, even cheaper than an anesthetic machine. So we're not talking about a Rolls-Royce, the 4K system, 3D, a run-of-the-mill entry-level laparoscope is even cheaper than an anesthetic machine. It's even cheaper than many equipment that are found in district hospital. So that is the stack itself. And the Gauteng provincial government, issued a tender where all regional hospitals were able to buy a laparoscope. All regional hospitals have a laparoscope machine. And the training hospital, they get a budget, which is called clinical training grant, which is basically to look at these innovative strategies of, treatment that are offered to patient. And government recognizes that the tertiary care centers, there are these, very important innovative strategies, innovative treatments that the budget of hospitals is not able to cover. So they have that money, and it's quite a sizable amount of money. Okay, now it has been cut, but a sizable amount of money to look at that. And those regional hospital training academic centers, so they're able to buy. For example, we bought a laparoscope in Jubilee. Jubilee is our training platform. So there's a lap scope there. OD Hospital has got a lap scope there. Breast Hospital is our training platform. There are 2 laparoscopic machines there. All of them they have a laparoscopic machine, so that when the registrars go there, they're able to have a laparoscopic machine. Now, you can talk about the ports. Now, the ports, you have metal ports, and many countries have shown that you can use these reusable ports. If you look at India, India is one of the countries that does a lot of laparoscopic work. And India is a poor country, just like us. It's not a rich country. And laparoscope there it is one of the areas where laparoscope is so well developed. And they use this reusable, trocars, to demystify this. So I think the short answer to your question about resources, it is not a very expensive thing, using the basic, for example, to suture that, you use a ruder knot, you use a ruder knot, chromic, we have a chromic there. So those ports, you re-sterilize them, they are metal ports, they're reusable, so it is not expensive. I think in terms of resources, I think it really requires a mindset shift that is not expensive. In fact, if you do long-term, you do an economic study looking at, for example, return to work. These patients, within a week, they are back at work. They don't stay in the hospital. Hospital stay, cost of in-hospital stay is reduced significantly. The economy, they return to work, and they don't come, the long-term complications for bowel obstructions, incisional hernias, you decrease that significantly. So if you look at global cost assessment, it's actually cheaper in the long term to offer this special laparoscopy. I think something that, again, that, we need to convince government that, it's not expensive. It is actually cheaper in the long term. It's almost like bariatric surgery. Patients who are obese, you offer them bariatric surgery, you cure their diabetes, you cure their high blood pressure. So long term, you actually decrease health cost on these patients.
Yeah, that's quite clear. No, thank you very much for that. I think that quite explains it. And I think it's good that government, especially in Gauteng now, has made that investment for both regional and district hospitals. Last but one question, Dr. Mashiro wants to know, given the different mechanisms in blunt abdominal injuries, is the approach the same as in penetrating injuries where laparoscopic surgery is preferred?
Yeah, I think that's an excellent question. I think I was really concentrating on penetrating injuries, anterior abdominal wall, penetrating injury. For blunt trauma, I think Dr. Mashiko is quite right. The mechanism of injury, actually the impact of injury is energy transfer is much more severe in blunt trauma. So blunt trauma, laparoscopy in blunt trauma certainly has not taken, we published a paper at the Scandinavian Journal of Surgery looking at the role of laparoscopy in blunt trauma. And now more and more papers are coming out really looking at the role of laparoscopy in blunt trauma. Certainly the injuries are much more severe, but it still has a role. We had one patient there, we had a fracture of the pancreas, from blunt trauma, anterior compression of the pancreas against the spine. He had a complete fracture of the pancreas. And that patient was treated laparoscopically. And once again, he was offered laparoscopy. We did a distal pancreatectomy. We removed the pancreas. We preserved, the spleen. The spleen was preserved. So again, it does have a role. Some of the patients that I showed here, for example, that diaphragm injury is a blunt trauma. The patient that had a motorbike accident, also ruptured diaphragm, was blunt. So it does have a role also in blunt trauma.
Yeah, thank you very much. There was in closing, before I call Prof. Jeff Wing to make the closing remarks, there was a question on AI, but I think you've answered it. But just for this, to make the colleague know that we didn't ignore the question. He was asking about possibilities of doing AI remotely when one person is in another country and the other one in a different country. But I think you've answered that question, that at this time, point in time, we're not looking at AI for this kind of cases for now.
Yeah, I think there's no doubt. I think it's certainly, I think the speed of data transfer is something that certainly can make it. But I think it's coming. I think without a doubt. I think now there is CG and speed of data transfer. Certainly, I think it's something eminently which is coming very soon, without a doubt. I think there's already discussion in China around that, but it's certainly something that's coming.
Okay. Thank you very much. I'm going to ask Prof. Wing, Jeff, to just come on and do some closing remarks. Thanks, Zach.
Thank you very much.
I'm not sure if we're able to allow Prof. Wing to unmute himself, Kamu. Or is he gone?
No, I'm here.
Oh, thank you.
No, I just needed to unmute. Thanks, Ray, for allowing me to say the final words. So, Zach, Koto, this was a masterly presentation, masterly in its content, masterly with the original research that you came to give insight into this new field of surgery. And I think masterly in the insight that you have of where surgery is going. So I think clinics, with these webinars, we should create a master series of lectures. I know other societies and organizations do this. And when a master class is announced, this would be a state-of-the-art type lecture. And I think, Zach, yours would be the first to fulfill those criteria. So as a physician, I'm trying to remember the wisdom of medicine and surgery. And I was told that, number one, the best combination for a patient is an aggressive physician, but a conservative surgeon. So I think part of your insight is that laparoscopic surgery certainly fulfills that requirement of elegant, concise surgery, which to me is the conservative approach. So, I thank you for that. The other phrase that's often bandied around is that the abdomen is the happy hunting ground of the surgeon. So I think in the setting of trauma, you've made this far more happy for the patient. So I thank you again for your presentation. And good evening to everybody, and thank you for attending.
Yeah, no, thank you very much, Jeff, for those kind words. Thank you very much, Jeff.
Okay.
Thanks a lot, Jeff, and thanks for this presentation, and thanks to all the colleagues of LobTeam, and we thank you for being with us, and Kamu and Anza, and we hope to connect with you again next week.
Thank you. Good evening.
Thank you. Good evening.